So I know you're an audience of entrepreneurs and innovators, and I'm bringing you a problem that I need some help solving. So have any of you been in an emergency room lately, okay, and had to wait there a very, very long time from severe overcrowding, okay? So it's hard to get care. And there are parts of this country where you can't get care at all. Our healthcare system has two problems that really could use great attention. One, we do not pay adequate attention to prevention. And so people are getting sick. Our emergency rooms are overburdened and we're going bankrupt. And we also don't distribute care well. So there are parts of the country where there is no care. So we have some problems that need to be solved, and we need your brilliant minds. I must admit the vaccines against a lot of the chronic diseases would be amazing. So I've been part of the healthcare system for a while, and basically it's given me an opportunity to see some of the problems from different directions, and I'd like to share that with you. So first, some history. Our healthcare system used to be mobile. In fact, the language of medicine is mobile: grand rounds, work rounds, delivery of care. And that was how healthcare came to you. But as healthcare became more sophisticated and technology grew, we then had to build an infrastructure to house it. And we moved healthcare into the hospitals. Moving healthcare in hospitals was a brilliant and effective and efficient way to do things, but we potentially have lost some things in doing that. The elements we lost were sort of the personal touch, the sensitivity, the understanding of context. And so maybe there's something we can learn by going back to our roots. I don't know if we said it, I'm an anesthesiologist. So how did an anesthesiologist come to be advocating for mobile health? I live in a hospital. As an anesthesiologist, my job is to put my patient into a reversible coma, keep them asleep and safe and stable through surgery, and then wake them up. To do that, I have to know them well, which is why we do a pre-op visit and why we read their charts, because we're going to have to choose which drugs. There's 20 or so drugs that we give during one case, and we have hundreds to choose from. So we need to know our patients well in order to pick the right drugs. We need to tailor it. That takes time. You want to have the pre-op visit and you want to read their chart, but it doesn't always work that way. So on one particular day, I was in labor and delivery, and a patient was wheeled onto the floor at great speed. She was pregnant and she was unconscious. The baby's heart rate was falling and was not coming back up, so she had to have a stat cesarean section. As we crashed her into the operating room, basically all I knew about her were her vital signs, which is not enough. Miraculously, it went well. The mother did well. The baby did well. It was a fantastic outcome. But I wondered why this had happened. So when she regained consciousness, I went to visit her to see, what had gone on. And turned out she lived near the hospital. She was from a working poor family. She had a job and she had health insurance, but she didn't have time to go to all of her prenatal visits. So when she started having a headache, she didn't feel she should bother her doctor with something so trivial. And she didn't know that a headache in a pregnant woman was a potentially very dangerous sign. She had a seizure at home and was brought into the hospital. This is a crisis for us in labor and delivery. And I was thinking, how do we stop things like this? And it was clear, when I spoke to her, the problem was lack of access to prevention screenings, lack of knowledge, and the lack of self-confidence that she should bother her doctor with something so trivial. And I knew that solving these problems could not happen in the hospital. So I went to the streets and asked their neighbors, what do people need? What do they want? How can we get it to them? Who else should we work with? And the answer was a mobile clinic. We created the family van. The family van is now 33 years old. It drives around the streets of Boston. We screen and refer. We educate and counsel. We're connected to all the neighborhood health centers. We're connected to the community resources. And what's really important, when people come to the mobile clinic, we help build self-confidence in them. And they leave understanding how and why to take better care of themselves. Fueled by the love and dedication of the people who work on the van, we have these amazing stories of lives that have changed. 2 decades later, there were roughly 2,000 mobile clinics around the country, all across the country. Most of them were funded by philanthropy. And most of the philanthropy we got because we tell the amazing stories that we were hearing. But that gets thin after a while. And so we decided we needed a concrete proof that we were doing good. And I had this idea that on the family van, at least, I was pretty sure that in 1 year, we would have prevented one low birth weight baby. And one low birth weight baby cost the hospitalization would be $250,000. So I thought, well, why don't they give me a little bit of money to run the van and we can, prevent bad outcomes. And that was actually the beginning of an idea of trying to figure out an algorithm to understand or to prove what the value of prevention. We looked at the services we provided. We looked at the emergency room visits that we prevented, and we converted that into a sort of an estimate of how much money we saved the healthcare system and turned it into what we called the return on investment calculator. And we put it on the web, made it freely available, and posted it. The website is Mobile Health Map, and it's our ROI calculator. So this is what we learned. We learned so much about the mobile health sector, which at the time, we didn't even know we were a sector, because we were all mom and pop programs telling our stories and getting our philanthropy. Now we actually saw who we were and where we were. So we knew what we did, where we did it, who we served, and we had an estimate of how much we saved the system. We had literally and figuratively put mobile on the map. And I thought now I had the answer to go to the healthcare executives with to get that funding we wanted. My request fell flat. The healthcare executive very kindly explained to me what is the wrong pocket problem. Namely, the pocket that would pay for the prevention services is not likely to be the one that is actually going to see the benefit of the prevention services. So in fact, Grado was doing good work, but it wasn't something to invest in. And at least our system is not based on this type of investment. This is what our system is based on. If an ounce of prevention is worth a pound of cure, we don't act like that. But in fact, I don't think any of us act like that. I mean, how many of us actually are doing a good job following how much sugar and salt we eat? I mean, prevention is actually hard. It's not fun. And our healthcare system was not designed to prevent disease. It was designed to cure disease. Where could we go with this? How to turn a system, and this is where innovation comes in. Our system is designed to cure. It's not designed to prevent. And we did just hear amazing ways you can prevent maybe asthma and things of that sort. But the rest of it is going to take our behavior change. Which brings me to the second problem. So I told you there were two problems. The second problem is distribution. Our healthcare system is not distributed evenly. There are parts of this country that the hospitals are closing, and there are parts where, even at the best of times, the geography was daunting. But then COVID came. And COVID was fascinating because one of the problems is, you might remember, it wasn't safe to go to the hospital. So we actually had to figure out how to get resources to people not at the hospital. And at that time, what was interesting, I heard a rumor that the folks in Washington were thinking about using FEMA trucks to get COVID testing out to the people. And after 30 years on the street, I knew that if you drove up into my neighborhood with a FEMA truck and say, "I'm here from the government, I'm here to help you," that wasn't going to work. Now that we had data of what mobile clinics could do, where they were, we actually, went and spoke to the COVID task force and convinced them that mobile clinics should be part of the solution, which was awesome. And they agreed. And in fact, there was a lot of new funding for healthcare centers to start mobile clinics, and they did. But what was really interesting is when people rolled these mobile clinics into communities, the people who got on, they wanted more. They wanted help with managing their chronic disease. They wanted help accessing the resources in their community. So they wanted what a mobile clinic could do, which is the personal, high-touch work that that was our bread and butter. Healthcare is not evenly distributed, but neither is disease. Disease is very poorly distributed. And this is a map of Boston where you can see the range, the COVID rate was quite variable by different communities. Well, Dr. Levy, another wonderful Dr. Levy in Detroit, had been looking at studying the variability of disease in Michigan. And he had developed a way of using de-identified health records to map disease and then understand where there was chronic disease. When COVID happened, he used this to deploy mobile clinics because he knew where the COVID cases were, so that's where he would deploy the mobile clinics. When the pandemic decreased, he then used the same geocoding to actually decide where to send mobile clinics that could manage chronic disease. And it was so successful. So he would find areas that had a high concentration of poorly managed chronic diseases, and then he would deploy his mobile clinics there and bring in sort of flexible, adaptable systems for responding to the chronic diseases. And it was so successful that, in fact, the insurance companies that were responsible for these lives of the people who had not been part of the system now created bundled systems for helping to support the mobile clinics, which brings us to the future. So, in fact, the original idea of mobile might be from the past, and what we learned from COVID was the past, but there's actually a future to mobile too. The fact that there are parts of this country that have absolutely no healthcare and no hospitals. And you've all heard of DARPA. Well, DARPA, who gave us, GPS and autonomous vehicles. Well, there's ARPA-H, which is the H stands for health. And their mission is actually to create hospital-level care in a mobile clinic to be able to get care out to communities that have no care, but it makes no financial sense to try to build a hospital. There's a program by Homeward Health where they're actually working with us with the mobile health map to look at how to use community engagement and community connections to increase clinical efficacy. And then there's another one that Mission Mobile, where they're actually going to do modular pods where they can design the mobile clinic to suit the medical needs. So there's a future in mobile. And of course, I can't wait until they, add what AI can tell us about where diseases are and how to treat them. So there's a future of mobile. And, as innovators, you might help us think about how to redesign the system to bring mobile back in. But one last point, the magic of mobile clinics is not just their wheels. It's a different model of care. It's a model that's based on relationships and listening and understanding the context. It's also a disruptive model of care. It breaks down walls. Our healthcare system was designed for sick people to come to us. Mobile clinics bring the care to the people. When we ask people who come to the family van why they come and how it feels, they say it feels safe, welcoming, comfortable, motivating. That's what we want. So our system is in critical condition, and at least part of the solution might be actually getting outside the walls of the hospital and going to the people. Thank you.